Bienvenidos al curso PreCongreso del ICBA, Instituto Cardiovascular 2020. Soy el doctor Fernando Botto, soy médico cardiólogo y jefe del área de investigaciones clínicas del Instituto Cardiovascular. En unos minutos le voy a hacer una entrevista al doctor Renato Lopes. Renato es profesor de medicina en la división de cardiología del Centro Médico de la Universidad de Duke. Él se formó, digamos, clínicamente en la Universidad de San Pablo en Brasil y luego completó un fellow en el Centro de Investigaciones de la Duke, donde ahora ocupa un par de cargos muy importantes ligados fundamentalmente a investigaciones clínicas. Él recientemente acaba de presentar en el Congreso Europeo el estudio Brace Corona, que justamente apuntó a ver si hay que suspender o no hay que suspender los inhibidores de la enzima convertidora o de la angiotensina 2 en los pacientes con COVID, y la idea es preguntarle sobre eso y también sobre otros tópicos relacionados a enfermedad cardiovascular, COVID y su gran experiencia en estudios clínicos. Hi, Renato.
Hi, Fernando. Thanks for having me here.
Okay, thank you for being here. It's a great pleasure for us to have your collaboration. And let's start with our interview. We have many general questions, and then we will try to talk about your trial, Brace Corona, which is very important for our practice. So, first of all, congratulations of having this fantastic Brace Corona trial that represents a great contribution to our medical practice, and particularly because it was performed in Brazil, which is a great pride for our region. I would like to start with a general question. How do you think clinical research on therapeutics has to be performed in a dramatic situation like this pandemic? I mean, which is the usual quality standards that you can resign against the feasibility of carrying out an RCT?
Correct. Yeah, so that's a very important question, Fernando, and we don't have an easy answer, unfortunately, because it is complicated. But I think we have been learning to do things more pragmatically, especially in the pandemic. And that means that it's a very thin line to do things more pragmatically and more efficiently, but without losing the scientific rigor, without losing the ethical aspect of clinical research, because it's very easy to get that lost when you are in the middle of a pandemic. And then everything you're trying to do can backfire and we have been seeing that with retractions of papers in major journals and major problems happening in trials. So it's a challenge to be able to do it right, do it more efficiently, but respecting all the steps, all the aspects that we know about clinical research that we cannot underestimate, because if we do that, we're going to regret.
Great. And how was your experience in your country, in Brazil? Because, you know, we need a great collaboration of physicians, centers, the people. So how was your experience in Brazil in this, you know, with all the dramatic situation also in Brazil? How was the experience?
Yeah, in general, I think the experience was very positive because we are able to stimulate physicians to do research that could not do otherwise first. So it was a good way for them to, for the first time, get involved in research. Secondly, we needed to manage people's anxiety and people's fear of the uncertainty that we all were living as well, because we are all learning about this disease. So it is really challenging to manage all those different sentiments that might happen during the pandemic. But at the same time, if you have a strong protocol and you want to answer an important question, and you are able to have the right people involved and explain to them that the best way to treat someone when we don't know what to do is to include them in a randomized trial, then I think is the critical piece for the success. Because we have this idea that guessing and the urgency situation, because we are in an urgent situation, we have the permission to do whatever we want, but we don't. because if we do that, we can actually cause more harm than benefit. So the best way to treat a patient when we don't know what to do is to randomize them in a trial, because in a trial, they are being supervised, they are being monitored, and the safety of the patient is in the first place. And at the same time, you are advancing science and you are advancing medicine, and patients are helping science and helping us to discover what works and what does not work. Because every time you have an answer that is a negative answer is also very important, because you might avoid people to be receiving a treatment that we know does not have any effect. So again, it's not an easy task, Fernando, but I think if you show people the contribution that they can do for the world, because that goes beyond Brazil. It's not just Brazil, or it's not just US. Whatever we prove that works will help the entire world. So I think when we are able to show that, and we are able to have trust from investigators involved, that we are all working together as a team, that there is no one leader or one person only, but it's a team of doing the work. Everybody feels part of the team. And then, as I used to say, Fernando, I think that that's the really true spirit of teamwork, which means make common people like all of us to achieve uncommon results, which is advanced science.
That's fantastic. I would like you to tell to the people the number of trials that you are running in Brazil. I know that there are 2 or 3 already published, and you have many more. What about that?
Yeah, so that's an example of a true collaboration, Fernando. We created a group in Brazil called the Coalition. And the Coalition is a effort that 8 hospitals or institutions got together to answer and to design right trials with scientific rigor, and join efforts in terms of site network and all the expertise to together answer all the questions faster that the world really needs. And that's what we did. So there are now 11 studies that we have done or are ongoing. They're all randomized. And our first 3 studies, Fernando, the first one was hydroxychloroquine with and without azithromycin. The second study was azithromycin on top of standard of care. And the third study was dexamethasone, so corticosteroids for severely sick patients with COVID. All of these trials, the first 3 trials were randomized. The first one was published in the New England Journal of Medicine. The second was published in the Lancet. And the third was published in JAMA. So I think that's an illustration of how powerful a country can be when we take the egos out, when we take money out, when we take personal interests out, and we only focus in the patients, and we only focus in having the best design to answer a question that the entire world would benefit from.
Great. I invite you, because here in Argentina we are fighting with egos, maybe, and other problems with organizations and compulsive treatments, and people is not being randomized so much as we would like to. But anyway, that's why you have a great job in these pandemics. Obviously, UK, United Kingdom, with a recovery trial, maybe is doing the best stuff for answer questions, but Brazil, I mean, is maybe under UK is the best country doing a great effort. So please now tell to the audience, which was the research question of your BRACE Corona trial?
Yeah, so in the middle of the pandemic, we also were seeing lots of hypotheses being raised by observational data. And we know how problematic that is, because every time you have observational data or observational studies, you can never address for the systematic error. And it doesn't matter how big your sample size is, you don't have the magic of randomization. Therefore, it's very difficult to define treatment effects. In other words, it's very difficult to define if something works or if something does not work, because the unmeasured confounders is always present and is impossible to address those unless you randomize. So one of the questions that came up in the beginning of the pandemic was that maybe people using ACE inhibitors and ARBs that we are so familiar for hypertension and heart failure could make the infection, the COVID-19, had worse prognosis, worse course during the hospital, because it could facilitate the increase of that ACE2 enzyme and therefore replicate easily the virus in the cell and get worse infection. But on the other hand, there were some observational studies showing that no, that maybe ACE inhibitors and ARBs, they are protective because they are vasodilator, they have anti-inflammatory, anti-fibrosis effect, and therefore is protective. So we have an equipoise. We didn't know what the truth was because none of these trials were randomized. So based on that, we decided to design the BRACE Corona, which is a randomized trial where we enroll patients with COVID positive using ACE inhibitors and ARBs, and they were randomized to stop these drugs for 30 days or continuing this drug for 30 days. Because by doing that, you are making the two groups identical and you are only seeing if there is any difference in outcomes if you stop or if you don't stop these medications. And we chose a very pragmatic primary outcome, which is a patient-centered outcome, which is the number of days alive and out of hospital at the end of 30 days. Because remember, that's what patients care. They want to be alive and out of hospital. And that's what we did. Very pragmatic. It was a collaboration between the BCRI, the Brazilian Clinical Research Institute, and the EDOR, which is the Rede D'Or Research and Education Institute. Very nice collaboration. Again, collaboration is the word. We have to collaborate. And we basically, from designing the trial to presenting in the European meeting, in the late-breaking clinical trial session, it took us 5 months. So in 5 months, we designed the trial, we approved the trial, we recruit almost 700 patients, we randomize, we follow them up for 1 month, we have 100% follow-up, and then we lock the database, we clean the database, and we presented at ESC everything in 5 months. And we were happy because I think we gave a very robust, for the first time, randomized data, evidence that we don't need to stop the ACE inhibitors and ARBs for patients with COVID-19. You can stop for other indications, but not for COVID-19.
It was a great result because that was very useful just to confirm some suspicion that we don't have to stop ACE inhibitors and ARBs. And it's incredible, this endpoint, the primary endpoint that you applied is days alive out of the hospital. It's a great endpoint because it takes also the complications that prolongs the admission. So was that endpoint used before in acute coronary syndromes or something like that?
Yeah, so we have used that endpoint, not as primary endpoint, but we have done some analysis on acute coronary syndrome trials because as you said, the nice thing about this endpoint is that it captures any ischemic event or any bleeding event that happens in the hospital because you're capturing the overall result. And is a very patient-centered outcome. So this have been used in other studies and have been used particularly in cardiology in an era that we care about what patients care. And it's a very, again, as I said, it was a very patient-centered and very pragmatic because you don't need to adjudicate, you don't need to, I mean, you just need to know if the patient is dead or alive, how many days they spend in the hospital. So very pragmatic.
Great. It was, and you also included almost 700 patients, more or less.
Right.
Great.
Yeah, we randomized about almost 700 patients within 2 months, basically 2 months and a half.
And you have a great collaboration also from the authorities, okay? Because I know that the authorities approved your trial in 5 days or 4 days, something very fast.
And I think that's another lesson learned, that we learned that it's doable to have fast approvals. Of course, the authorities in Brazil are working really hard. They're working 7 days a week, 24 hours a day. And that's not sustainable. We need to learn that. But that's okay. When the pandemic is gone, we don't need to get approvals within 2 days or 3 days. But maybe we can get approvals within a month,
Yes.
and it will be already enough. What we cannot have is approval that takes 1-2 years to get approved, because that makes us much
Yes.
less competitive.
Yes, yes. So, just a general question. You know, we know that patients with advanced age and comorbidities, they have worse prognosis with COVID. But I like to know your opinion about those people who have hypertension. Because, you know, hypertension is very common, let's say with high cholesterol, but not cardiovascular disease before. So do you think these patients or these people with COVID or hypertension have increased risk? Because you know the association between hypertension and age, but everybody here, the people, the physicians ask you, hey, I have a patient with hypertension. Is a patient at risk or no? Do I have to go to the work or not? What do you think about that?
Yeah, I think it's a good question. And I think the short answer is that we just don't know. I think that it's very easy to believe that those patients are high risk for worse outcomes in COVID patients. But it's not very clear to me, based on the data that we have so far, if hypertension independently can increase risk on top of COVID-19, because hypertension is also a marker. It's not just a risk factor, but it's a marker of risk that carries a lot of other things, including age, including atrial fibrillation, including heart failure, including diabetes, including risk for strokes. So I'm not so convinced if hypertension per se is an independent risk factor for worse outcomes in patients with COVID-19. We know for sure it's a marker of risk, and if patients have hypertension as a marker, they are at increased risk of really having worse outcomes. But we don't know, and nobody showed that if you treat more aggressively those patients, they're going to have better outcomes just because they have COVID-19.
Perfect answer. I like that. So just you mentioned atrial fibrillation and maybe taking advantage of your expertise in DOACs, particularly in apixaban. Do you think there is a place for DOACs before or particularly after COVID-19?
Well, that is a great question. But Fernando, instead of saying what I think, which doesn't matter, I'm actually doing the trial. So I'm doing a trial in Brazil called the ACTION study. And the ACTION study is basically getting patients with COVID-19, D-dimer elevated, and we are randomizing to rivaroxaban, full dose, 20 milligrams rivaroxaban, or just enoxaparin prophylactic. So enoxaparin 40 milligrams once daily prophylactic versus rivaroxaban 20 milligrams once daily for 30 days. Even if you go home, you continue on rivaroxaban 20 milligrams per day. And we are planning to randomize 600 patients. We already randomized 200, so we are 1/3 gone. And we are hoping to give the answer. First, is there a role for full dose anticoagulation? Second, is there a role for NOAC? I think it's better to answer to a trial with data than just with my opinion.
Renato, I think you are doing the right things because we need fast answers. We don't need answers about COVID in 2 years. We need the answers nowadays that in the middle of the pandemics, we know that we have maybe 1 more year of this stuff before the vaccines. But you are the people that we call trialists. You are a doer. You are doing many things. That's why I congratulate you and your group, and you are doing a great job. So I'm going to finish this interview because I know you are very busy. I want to thank you for being here with us, just talking about many topics in about COVID. And you are doing many trials, and your collaboration is incredible. I think Brazil is doing things very well. And we here in Argentina, we have to learn a lot maybe after pandemics, we will have to see some lessons coming from your country. So maybe we will have some problem with the soccer stuff, and that's the usual. but we have a great admiration about you doing research. So thank you very much because you are here with us, and we will have opportunity to discuss other topics in the future. So thank
you very much, Fernando. I really appreciate the opportunity to share some of my thoughts and some of the work we are doing. And again, I truly believe in the power of South America. And if you think about Argentina and Brazil together, is almost 75% of the entire South America. Think how powerful this can be. And I think there is space for collaboration. There is more work than people and I think we need to be able to learn how to work together, because that's the word of the 21st century in academic medicine is collaborate or perish. If you don't collaborate, you're done. You're killed.
And you say the exact thing, because you said we have to fight the egos. We have to fight the egos and work together, definitely. So, Renato, a great pleasure.
Thank you so much again. See you next time.
Bye-bye. Thanks.
Bye-bye.